Hi there, and welcome to the FacDev Lounge podcast, your faculty development podcast for Dalhousie Medicine, New Brunswick. I'm Dr. Sarah Gander, a pediatrician here in St. John, and very happy to bring a colleague and a friend, long-term friend, here today to talk to us about interprofessional education. So I get to welcome Dr. Marc Nicholson. Hey, Marc.
Hi, Sarah. Thanks for having me. And in full disclosure, I did the math, and this fall I will have known you for 30 years.
Oh my gosh!
Yeah.
How dare you?
During
How dare you say that
in high school.
Wow. Yep. So because you would have been in grade 12 when I was in grade 10.
Yep.
And then hanging with the folks at St. Malachy's and a bit of Broadway and whatnot.
Absolutely. That's it. Yeah.
Yeah.
So I'm happy to be here today to talk about interprofessional education, and because I've known you so long, and we're so good friends, I'll have to put my professionalism hat on and not get too down and dirty with comments, we'll say.
Well, it's actually terrifying to think of the stories you could tell. So let's just be thankful that this isn't a live recording. Note to self not to have you on any type of live podcast recording. Oh my goodness. Well, thanks very much for coming. I think this is a great topic. I must say, like, my own experience with medical education was, I feel like I have been around to sort of hear the words used now, interprofessional education, as a contrast to kind of some other ideas of what were happening. But I mean, right out of the gates, I think we should just, like, what are we talking about? We're talking about people working together.
Absolutely. So some of the history of IPE, I mean, interprofessional education is what we're talking about. And there's a difference between interprofessional education, which in theory happens when the World Health Organization's definition is when one or two or more than two health professionals get together to learn with, from, and about one another. I think that can happen in the post-licensure timeframe as well. Certainly residents are involved with interprofessional education. And I think that whenever we do a pediatric high-fidelity simulation in our PEDS department, that's still interprofessional education, but a lot of the people are already post-licensure. There's practicing nurses, there's practicing physicians, there's practicing respiratory therapists. So I don't think we should always narrow the focus and say that IPE is done by or done to students, because I think when it comes to this, we're all students. And interprofessional education, the hope is that it will lead to improved interprofessional care and better, more positive patient outcomes. So the with, from, and about is the major description of what IPE actually is. It can happen in a large event where you've got 400 or 500 students involved, or if you're on the Dalhousie campus in Halifax, you might have up to 1,000 medical professionals who are collaborating for different activities. But it can happen at the bedside if there's a few students from different realms getting together and meeting. So I think that it happens all the time, all around us, and we may not necessarily recognize it or name what exactly it is. But the goal always is to try to improve interprofessional care for the benefit of patients. I think sometimes in the planning of these educational events, sometimes maybe the long-term goal or hope of the activity is sometimes kind of forgotten about, because interprofessional education is an accreditation standard for all healthcare programs in Canada. So it's meant to be much more than a box to tick, but I was addressing a group of students the other day, and I kind of jokingly said, it's an accreditation standard. We hope you like it, but even if you don't, we're still doing it because we need to. And that dates back to in 2002, the Roy Romano report on the future of healthcare in Canada came out, and one of the ideas around that was that interprofessional education should be happening, that students should be learning together, in the hopes that they'll be able to better work together in collaborative centers. And if you think about it, how can people who've not been taught to work together, interact together, be expected to be able to do it on day one of performing their job on, say, a busy inpatient floor or a busy OR service, or really anywhere that there's more than one health professional gathered? So for going on 20 years now, it's been emphasized in Canada and also around the world as well. I would say certainly North America, maybe at sort of the leading edge of these things. And there's a meeting that takes place every couple of years. It's meant to be an international meeting, but it certainly has a North American focus. It's called Collaborating Across Borders. That's happening next month, I believe it is. Virtually, it's being offered by the University of Toronto. So that's upcoming. It's still an interesting field in that you get to have a bit of fun and design new events. No knock on clinical skills, but there's only so many ways to teach people to auscultate a chest. There's lots of innovation and new ways that you can try to get students to interact and learn together.
Well, so since you've already kind of given away how old we are, I was just thinking about maybe the way that like this was implemented when it started to become a thing. And so I was in Newfoundland, and it was sort of the advent of like I'm going to say this wrong, not competency-based or case-based learning was just sort of starting out of, like McMaster, and then Dal had adopted it. I ended up going to MUN, which was still very much the didactic classroom.
Yeah.
Type teaching. And then I think like smartly recognizing that people did need to sort of learn together and from one another. The beginnings of that was, sitting in a room, like one of the study rooms or whatever, or one of the case rooms, and like going through the case. And I think other people were invited. Like I think some nurses from the nursing school were invited. But maybe that was just sort of like it's evolved from let's go through a case together and talk about what everybody's role is to simulation to, maybe the doctor not being the one that sucks all the air out of the room. Like, how has it changed over time? Because we're just sort of, I suspect, evolving to have it grow.
Well, I think one of the major things that you've hit on is that that was probably in an era of ticking the box and saying that we offered it. I can think back in 1998 when I started medical school, which feels like 100 years ago. It was last century. But we had in the fall, probably we were 2 months into med school, and we had what was, in hindsight, it was an attempt at interprofessional education, where similarly we had a tabletop case where we were interacting with students from other programs. But we weren't on the same level playing field. I was 2 months into my program. And when you think about one of the major aspects of interprofessional education, we call it one of the key parts of the framework to interprofessional education is role clarification. And I would argue that most students in most health programs don't fully understand and appreciate what their role is when they're 2 months into their program. And I was paired with a fourth-year nursing student who unfortunately had already had some negative experiences interacting with physicians in the hospital. And I barely knew where the hospital was. I knew vaguely it was across the street from where we did some learning, but we weren't into our clinical skills programs yet. We were doing some, focus on history taking. But this individual really kind of steered the ship, and unfortunately, based on their experiences, it really kind of was negative for them, and it kind of colored the everyone's attitude towards the activity. And it was like, well, we survived that, but please don't ever make us do that again.
Yeah, I think there was a really negative attitude towards those things. It was kind of, and not even like the fluff category, maybe a little bit of that, but more just like, oh God. And which is really funny because, like it's when we accept students to medical school, we value so much their experience of collaboration and like working in the community and things like that are so valued. And then all of a sudden you like, land in medical school and we like, prefer to be isolated with our people. There's some sort of like safety in that. And it feels uncomfortable and unsafe to be with others.
Yeah. And I think another lesson that I when I got involved in IPE, I started in my role in January of 2017, and Sarah and I also did our Master's in Education together, and we actually did a whole course on IPE. And one of the big takeaways in sort of my learnings around IPE is that despite us recognizing that it's important, it's an accreditation standard, it still doesn't get the love and respect in the the carved in stone curriculum I think that it deserves. And my IP activity in Med 1, I think it took place at 7 p.m. on a Tuesday evening. And as soon as you're putting things at 7 p.m. on a Tuesday evening, it doesn't suggest it's as valued as your cardiac physiology lecture that you have during regular hours. It infers that this is somehow othered or othering. So we've tried very hard to have protected time in the schedule where IPE takes place. But even this year, I've seen a couple of times where one of the academic blocks kind of takes preference over that time slot. So it's an ongoing issue, and certainly in St. John, we do have a very interesting scenario. I'll say it's unique in my experience to most of North America. I've been to that North American meeting twice, and I don't think that I have found anyone who's quite as interesting as we are at Tucker Park. That's sort of the shorthand for the campus. We have UNBSJ nursing students who are involved. We have Dalhousie Medicine New Brunswick learners who are involved. And right next to the DMNB building, DMNB is across the street from the nursing building, but directly adjacent is the New Brunswick Community College Allied Health Education Center, or AHEC. And there's many programs for health that take place there. And so we end up collaborating with faculties from 3 different academic institutions. So in Halifax, Dalhousie has 20-some programs all within the banner of healthcare learning. It's very simple, or it's more simple, I guess, for those various deans to get there and say, this is to happen, implement it. We have the challenge of it's 3 different academic institutions, let alone several programs within NBCC, in order to coordinate schedules. So it's no surprise to me as one of the faculty that that's the reason that I spent all day Saturday involved in a high fidelity simulation activity on campus. And it was awesome. It went really well. This is the second year we were able to be back in person. We had all but organized and ready to go our activity in 2020. Friday the 13th was sort of the last normal day. That was the day that school was announced that the kids weren't going back to school, and we were scheduled.
It was Friday the 13th when that happened.
What's that?
It was Friday the 13th.
It was Friday the 13th. Yeah.
People don't talk about that enough.
We just blocked it out. So many things we've forgotten in the before times versus whatever this is now. But anyway, absolutely. We were meant to have our event. The event is called Partnering for PADI. In that PADI is the name of the high fidelity simulation equipment, and we're partnering because we're different programs getting together. So we were supposed to do it 8 days after the world ended, so to speak. So it was kind of disheartening to have to just cancel that event with all of the planning that goes into it. Someone had said the other day, we started meeting in probably August to pull off this event this year, and I think that there is so much human resources that are put into these events. And unfortunately, sometimes the students don't necessarily know, or I'd argue necessarily appreciate how much goes into making this event happen for them. I would say that largely, almost to a student, the feedback is generally felt that, wow, that was a good activity. I'm glad we did it. But sometimes there's a lot of reservation around the idea that they have to give up a portion of a Saturday. And I get that, I sincerely apologize, but that's how we're able to manage to do IPE. In a perfect world, it would be lovely if it happened, all day on a Monday or something like that. But the curriculum just to speak to Dalhousie Medicine New Brunswick, the curriculum is so constructed that you can't just give up a whole day sort of during the week. So I'd say that's one of my challenges that I recognize and my colleagues recognize, but there is some time that is protected in the schedule for later in the day. So we don't start events at 6 p.m., but we might start them at 4:30 and they might go to 6 p.m. And we only have a couple of those in the entirety of their calendar.
Does that sort of reflect, though, this is going to be a crusty old thing to say too, is that medicine's kind of not a 9-to-5 job anyways. And we all are kind of on this ever, long quest to to have, balance, whatever that means. That's a different podcast probably, but, that sometimes to really kind of accomplish those goals, you do need to kind of be nimble and be flexible and just sort of figure out how it works in the long term for you, because it is so valuable. Sometimes I feel like there isn't just that trust that I don't know, you don't want to be that, we know what's good for you, but this is like such a valuable exercise when you think about when you get out, what you're actually doing and who you're actually working with, and that to be able to have that opportunity just actually makes your life so much easier if you've gained some competency in collaborative care like that.
Well, that's it. I mean, everyone who's in training for this type of activity, unless they manage to get a very niche area and specialty in which to work, like they're all going to work on a Saturday, at least one, right? Even if it's during their training, it can't be avoided. To your point about it not being a 9-to-5 job, right?
Do you guys ever kind of go outside of the medical grouping of people? Like, I just think how many people you and I work, and everybody listening would work with, that, aren't necessarily healthcare professional trained, but, are certainly part of the team, and right down to, who knows how health systems work the best? Well, our administrative assistants, frankly, because they have to navigate it for patients and for us all the time. And that's just another interaction and another sort of relationship that requires some understanding. So I guess, I just wonder, do we ever bring in, the social worker, the lawyer, the teacher, the other people that we work with all the time for families and for patients?
Yeah, that's a great question, and I guess the short answer is it depends. Going to that North American conference, I went to a workshop the first year I think I went, and it was interesting in that sitting at the table, there was an individual next to me from Toronto who worked for, 30 years as a police officer, and after completing that career, achieving a high level within their local police department in Toronto, they'd gone back and they were doing education, and they were there from an interprofessional education point of view about bringing some of the learnings around interprofessionalism to go back to teaching in a program that helped develop correctional officers. So it certainly, in theory, is put into different places. But I would say from a practical standpoint of view, it sort of depends who's all at the table. So in Halifax, certainly interprofessional education would fall under the umbrella of programs such as social work. As you would well know, we don't have a social work training program right here in St. John. So it would sort of depend on what the activity is. And certainly within the curriculum in Med 1 at least, they're meant to complete a mini course. And that's on offer from Dalhousie, mostly in Halifax. But those groups would include potentially students from social work, as well as other professions we haven't named yet, because again, we don't train them here in St. John specifically, but occupational therapy, physiotherapy, speech language pathology. We have a stroke event that we've been running for a number of years, and in the past, there was more of a tabletop discussion around building a care plan for a patient recovering from a stroke. And when I fell into my role, we were able to bring into existence an in-person portion where we started it in a January month because we knew that we had respiratory therapy students. No, I'm misspeaking. Physio, occupational therapy, speech language pathology in St. John for a clinical block. So the learners in Halifax would have done the activity in November. We scheduled it in January so that we could actually capture when those learners were there. And that activity has evolved over the years. We've included dietetic students in that. We've also, one year we invited spiritual care to take part.
You took
it's certainly, it's not their bread and butter in terms of, being part of the team to provide post-stroke care. But they found it very valuable and interesting because in their field and their training, they're working within the hospital system, but they're almost parallel to the delivery of the healthcare. So just as an observer, they found it was really valuable. And we gave them an opportunity to speak as to, if we were asking you to come in and take on a role with this patient, what might that look like for someone who is a practitioner within sort of the realm of spiritual care. So it has been done, and I've tried to make connections with St. Thomas in Fredericton, because, again, recognizing they have a school of social work. And again, I'm sure it's challenging for them to be able to say that their students have participated in interprofessional education. We haven't managed to come up with a project to work together with, but it is sort of on my, if I had a dream board sort of a thing. But, these thoughts have certainly occurred to us. That's all right.
Yeah, no, I was just thinking, like, my mind was just kind of thinking all the people that you do interact with, spiritual care was on the tip of my tongue. And then, we're pediatricians. So like child life, I was thinking, and then even like the times that you don't realize what resources are out there to help you. Like, I think the times that I've gone to see Tim Christie to talk about an ethical dilemma, like just from a philosophical standpoint, and that kind of stuff is just really important competencies. Maybe I'm thinking selfishly for me to know as a practitioner, but really anybody who's like involved in the care of a patient or family. So
yeah.
Well, it's nice to hear too that it's not just like acute care situations where like it's a simulation where, somebody's coded or something terrible has happened, that there are opportunities to even talk through kind of a, less adrenaline surged case, just so people which is more common anyway.
Right. So on Saturday, the activity that we put into place is called Partnering for Patty. And it does involve high fidelity simulation. And for our medical learners, it's the first official time that they have exposure to high fidelity simulation. So we've been working hard to expand what all, it's not a block really, but building up a few pieces of competency, say, towards in-professional simulation. So this year we had a lecture delivered by our emergency department, sort of just an intro to sim talk. We also had an opportunity to have them come and meet the sim equipment so that they see what it can do, so you're not freaked out when the mannequin blinks at you for the first time. Because the first year I participated, I didn't realize that the med student who had these, big shocked eyes and was frozen for a moment, it's like, oh, that's the first time they saw a high fidelity mannequin. Anyway, when I went on to get my sim instructor course, I realized that's not the right time for someone to meet the sim equipment. So we've actually expanded it, and this year the Med 2 students are not required to do an additional mini course, which is, I would say, a big achievement, because I think they all like the experience, but this way I'm actually allowed to give them sort of the blessing of, and you don't need to have another 8 to 10 hour commitment, because Partnering for Patty has, as it's aged and evolved, we now have enough pieces or components to it that I can justify that it actually is a mini course for these students. So on the day they turn up, and really they're booked off for about an hour and a half, they meet their group, and the simulation that we did this year involved the patient having had hip surgery. They were post-op day 5. They're at home. They had a fall. We involved a Confederate, nothing to do with the U.S. Civil
Revolution?
War. No Civil War reenactors. But basically, we have we would call them in typical settings a simulated patient, but they're not actually the patient in this setting. So they played a family member to Patty, depending upon the age of the simulated patient, who's either an adult child of Patty or an adult sibling of Patty. And they went to their home, found them on the ground, called the ambulance, and they've arrived. And the students are basically the first point of contact with them. And the case is really not around acute care. It's not about running ACLS algorithms. And we tell the students that because really, thinking back about the Med 2 students, they don't have that exposure unless they've happened to do an emerge elective, or in another life they were, say, in nursing, or they were a respiratory therapist or something like that. So the expectation is much more around working on communication, on team building, on role clarification, really getting back at the IPE competencies that we talk to them in lectures about. And this is them able to prove and see in real life what do those things look like. This year we built in a little bit of conflict, intrafamilial conflict,
Spicy.
just to see how they react to it. Statements like "get that person out of here." How do they respond when the patient who they're looking after tells their adult family member to buzz off? How well do they de-escalate that? Does someone take on the role of trying to calm the family member who might be agitated when told to buzz off, because they're meant to be a loving family member and they care about their sister? And in this particular setting, the sister is in pain and not necessarily wanting their grumbling comments about you need to quit smoking, you need to do this, these sorts of things. So I think the students handled it well, and it was a really great activity to put off. But again, focusing on we'll say the less sexy areas of simulation. Everyone wants to intubate the mannequin. Everyone wants to do an advanced airway if you're a respiratory therapist. Everybody wants to cardiovert the patient. So I think there's many ways to use the high fidelity simulation that don't involve those high adrenaline situations. So I think that students inherently, when you tell them that they're going to do simulation, they assume it's going to be the high acuity piece, when in actual fact it's another way to add some fidelity to an interaction, as opposed to, I would say this to the patient. We'll go ahead and ask the patient the questions, right? So it turned out really well for us. So I'm happy we were able to do that. And I can tell you about something very novel we did this year. I've facilitated this for a number of years. And one thing I notice is that in the morning when they arrive, they sit separately. You tell them to interact and chit-chat with one another, but everybody wants to put on their best face. Everyone says, I'm representing me, but I'm also representing my program. I don't want to look like a dum-dum in front of all these different programs. And so you can just, the anxiety, called performance anxiety, it's palpable in the room. And so in 2019...
It's just like the unknown, though. It's just sort of like this sense of like, oh God, what are they going to ask me to do?
Exactly.
It's like I don't know. It's like speed dating or something. Like, oh God.
Well, we tell them at various points, you're not doing ACLS. The patient's going to be fine. You're going to be fine. But I don't know that they necessarily believe us until they've survived. And then afterwards in the debrief, almost to a person, they say, wow, that was so much better than I thought it was going to be. So I went to a session in 2019 at one of the Collaborating Across Borders conferences. The University of Minnesota, as part of their IPE curriculum, they developed an IPE escape room. I was able to purchase their cookbook as to how to implement it. And with the help of UNBSJ Nursing, the faculty there really kind of took it on. And our goal was to put a group of, say, four to six groups of students through this activity before the high fidelity simulation. And we were measuring, our plan was to measure pre-test anxiety scores, that sort of a thing, kind of looking at that performance anxiety piece. Our hope or our hypothesis would be that the group who have met, worked together, maybe even had a little bit of fun together, are going to be less anxious and better able to sit down or not sit down, they're on your feet, but to take part in the simulation activity. And as I mentioned earlier, that was the year where a week before it was to happen, we had to cancel the event. So I'm happy to say that this year, 3 years later, we were actually able to run the escape room last week.
Oh my gosh.
Yeah, the students really had a great time. We haven't had a chance to look back at their feedback. And we also did run the anxiety measures on Saturday. So hopefully we'll get a little bit of information from that. And if we were going to put all the students through that escape room experience, unfortunately, it would take as much coordination and arranging as the actual event that we're running. But I think that if there's value to it, I think that there's a whole extra layer that the students could get out of the activity if they were less stressed about just going ahead and doing it. And some of the feedback we get is everybody says, this is great and we should do more of it. And one of the practical nursing students said, we should be doing this earlier in our training. Because of the length of the time that the practical nursing students train, they're at the end of their training and they're like, I wish we had done this in our first 6 months, right? So
maybe there's some prevention to that too. Like when you you think of your story about, being with a late training nurse and sort of they'd already had some negative experiences. I mean, there's a component of IP I can only imagine that's a bit sort of upstream and meant to be preventative. Like, here's hopefully how you can improve your experience. I mean, I guess the end game is also like, let's train people who aren't awful to people as well, but that maybe you can get ahead of that a little bit if you can get them earlier in their training.
Right, and I'm happy to say that we do have a first year event. It's a little fun named. It's Tucker Palooza. It takes place. All the students are in their first year of training. It usually takes place in either September or October, so they're really new in their programs. And as I had mentioned earlier, from a point of role clarification, we don't expect that they fully appreciate and grasp what their role is. So we wouldn't expect them to be able to, be a full ambassador for the profession to these students and tell them all the intricacies of what goes into their role in the profession. But the point is to have an early exposure so that when we talk about IPE down the road, there's at least some recognition of the fact that, oh yeah, we learned a little bit about this. But even at that early stage, very often the feedback that we get is they'd still like some of that role clarification piece. So one thing that we've done for the last several years as part of that is for all the different professional programs involved, we have a faculty person do kind of a 2 to 3 minute elevator pitch and say, like, what all would you want to tell the world? Here's your audience. Tell them about your profession. What are the interesting pieces, the surprising pieces? And obviously, some people can do it right off the cuff. Some people feel that they want a prepared script. But it's interesting to include that, and the feedback has keep doing that. We like to learn a little snippet at the very least. And I'll be very honest, because the scopes of practices are kind of ever expanding and changing. I learn something every year, every couple of years about some of the nuances of the practical nursing role, for instance, or the personal support worker, PSW. So there's always things you can learn, say like old dogs and new tricks, but hopefully the facilitators and the faculty are learning something as well, in addition to the learners that we're trying to support and educate.
And everybody's scope of practice, I feel like, seems to change and blur and whatnot, even when we think about like pharmacists and of course some of the nursing folks in different sort of stages. Let me ask you though, like, is it sort of inherent to the medical role? I'll be vulnerable for our field here, that even in the early stages, there's something about being the medical student or the one who's going to be a physician that just societally, or like it's just imprinted in our DNA, that we tend to can't help ourselves but to take over a bit, can't help ourselves but to, I said, suck the air out of the room earlier, and just, what is it about us that, the day you get into medical school, it just seems to lean in that direction a little bit? And what, if anything, should we be doing about it? Is there emphasis on that, like kind of de-escalating that?
Yeah, so I think it's important that whoever is the faculty person sort of doing the introduction to IPE, and I've had the, I'll say pleasure, of giving their framing lecture for Med 1 and Med 2 for the past, I can't tell time during COVID, I'm going to say 3 years. I've delivered it in person. I've also delivered it on Microsoft Teams, where you have no faces. And my wife had asked me, like, how did that talk go? And it's like, I have no idea. I'm screaming into the void, and no one gives me any context clues by smiling or sticking their tongue out. But I think that it's important, however we're delivering those lectures, that kind of addressing the elephant in the room, in that just by sheer nature of the fact that you have to have at least one degree in order to get into medicine, you are going to have more, at the very least, life experience than a lot of the people who have just started their program from high school, right? And no knocks to, people can have lots of lived experience by the time they're, finishing high school. But people have had all of their different careers. Some of them have a PhD. So we often will get looked or leaned on to, like, well, you're supposed to be running this. What do you think? and sort of just trying to say that, that's not the goal of it. The goal is maybe the group needs a bit of leadership, and we hope that the facilitator will provide that, but maybe speak up when it's appropriate, but don't just by default take over. And it's interesting when they get into some of their activities that involve IPE, they are very much on level footing with a lot of the learners, because their second years for this simulation activity, they have some clinical exposure, but the nursing students probably have slightly more in terms of hours in the hospital with patients. But even in those settings, I think that I don't know if it's a societal thing, but very often there is a moment where the students turn to the medical students and said, well, you're the doctor, or you're meant to be the be all and end all here. The
most responsible person in the room, or something like that.
Well, and as we're working towards this activity, we often will say, like, this person is in medicine, but they're not fully fledged. They're not fully formed. They're not an MD yet. So they are a learner just like you, and you may have more bedside experience than them. So please speak up, right? And there's a phenomenon of sort of shared leadership or evolving leadership that might happen through this. And the med student might be a quiet soul. They might have lots of book knowledge, but I've seen it where it's the practical nursing student who maybe they have a whole life before they pursue nursing, and they're the one who effectively leads the group. Or maybe it's a nursing student in the Bachelor of Nursing program who kind of runs the show. And you would guess based on how they carry themselves. They say, well, geez, were they a practical nurse before they started the BN program? Because we do see a number of students who are in their bridging year. They are a practical nurse, but they're opting into doing the Bachelor of Nursing program. So it's very interesting to see sort of that mixed bag. I would say that there's a lot of respectfulness that goes on. And I think the goal is for it to be a safe place for the med student to say, geez, I don't know. Does anyone know? Yeah. I know that I should order a drug here. Does anyone have a suggestion? I certainly don't know the dose of the drug that I don't know I'm supposed to give. So,
I don't know what the drug is, and I don't know what the dose is.
Right. I'd like to give an appropriate dose of a drug. That's obviously not how you order drugs in real life.
The Google helps sometimes.
That's true. Yes. Hey, pharmacist, what's an appropriate drug and dose in this situation? And we say that with tongue in cheek. We love our pharmacists that we work closely with at St. John Regional. Shout out to Peter.
Absolutely. But Marc, this is an incredible amount of work, but I just feel like there's so much opportunity for faculty to get involved. So let's talk about how people can get involved, and then how the heck it happens for distributed sites. So how can people get involved?
Right. So as a faculty of Dalhousie Medicine New Brunswick, you get a lot of emails about recruitment. I can appreciate it various times. It's overwhelming to even open that email. It's easy to delete it. With IPE, there's a couple of predictable events that take place. We usually have one in the fall, and we usually have this one that takes place in the latter part of March. We're trying to avoid snow days and whatnot. And if it's a one-off and it's something that might intrigue you, we had one faculty travel from Fredericton to come and participate this year in Partnering for Patty. The reason they came this year is they had such a great time last year. And they took it upon themselves to actually do the Royal College simulation course, which is no small feat. But this is how they kind of dipped their toe into the world of getting more familiar and interested with simulation. And they're very excited to have more opportunities for simulation, which I think is great. Because certainly simulation, spoiler alert, it's not going anywhere. It's going to be more part and parcel to training, right? So I think that if you have an interest in simulation and you don't have a sim instructor course, that's fine. We truly have a mixed group of facilitators. Each of our sites has 3 or maybe 4 facilitators involved. Some of them have expertise in essentially functioning as a sim tech to run the equipment. That's not in my skill set. I learned it very basic, but I haven't even turned the equipment on in 3 years. So I need to defer to the person who knows how to run the machine. I have lots of facilitating experience and debriefing experience, but I rely on my colleagues who know how to make the mannequin do what the mannequin needs to do. And sometimes you have someone who's an interested faculty person, and they say, well, geez, I don't really have any sim involvement. Well, you can easily be the third or fourth person in that group, get involved, see how the debrief goes on, and then make some contribution to the debrief yourself. So I'm certainly open to anyone who would like to come at various levels of training and experience with simulation. It predictably happens in March, and we're always looking for facilitators. I hope that when we have a mixed activity like this, that if our students account for, say, 30% of the students participating, my goal is always, well, let's try to recruit 30% of the facilitators that are needed, just to truly be collaborative and not assume or rely on the fact that our other colleagues will just fill that void. Last year, in particular, in 2022, it was our first year back to the in-person simulation, and we had an amazing cohort of people traveling from places other than St. John. We had 2 or 3 people come from Fredericton. We had 1 person come from Upper River Valley, and we had someone, I believe they came from Perth Andover, and certainly they had a good time. I invited them all to participate again, but with various schedules and conferences opening up to happen in person, only one of them unfortunately was able to come back, but no one blew me off with a "don't ever contact me again" email. And similarly, for our first year event, it's back to happening in person. Our goal with that is always to have 2 facilitators, and we'd love to have groups where there are 8 learners. But for that particular event, it's closer to 350 students. So unfortunately, often we never hit our target. Our target would be to have something like 50 facilitators in order for each group to be co-facilitated and have a nice small group of learners. But unfortunately, we end up with one facilitator and a group of 10 or something like that in order to accommodate all of the students. So if people are interested in learning more about interprofessional education, you can certainly include my contact information in the show notes, because you might be someone who has lots of experience with interprofessional collaboration, working in healthcare as part of a team. Whether it's something like, I think about my own life, I practice very interprofessionally as well. I'm involved with the diabetes clinic, where we have highly skilled nurse educators. We also have a dietitian who's part of our team. I work in cystic fibrosis, where again it's an even bigger team. We have a nurse navigator. We also have physiotherapy involved. We have dietetics involved. We have pharmacy intimately involved. We also have respiratory therapy attached to that clinic. And at an arm's length, a lot of our chronic disease clinics do have other services like psychology or social work attached. So sometimes when students need to make up an activity that they have missed for a variety of reasons, I send them to one of these interprofessional clinics, and they might provide a reflection on sort of what they learned from the different professions that are involved. So there's lots of people who practice interprofessionally or provide interprofessional collaboration. They may not think they have a lot to say about interprofessional education, but they can talk about how it is day to day working as part of a team. And I think you can bring that experience and be an excellent facilitator for Tuckerpalooza, the first year event, which is much more introductory. So I've plugged all my pluggables, as they say, on various podcasts I listen to.
Well, I think it's brilliant that you're our local champion here for our distributed campus and then for the sites in New Brunswick as well. I assume you have a partner in crime in Nova Scotia that you're not meaning to deliver all this curriculum for DMNS, as we say, as well. So you're not alone, I hope, in some of this work and ideas and things.
Yeah, so Dr. Anu Mishra is I always pause and freeze about assistant and associate deans, but she's in charge of clinical skills as well as IPE, and she's based in Halifax.
But maybe it's just nice to know too that like these distributed campuses, which are popping up all over, and like there'll be a new one in Cape Breton soon and whatnot, I believe that the importance of having a local champion really identified and somebody who's supported to be able to pull off something that isn't just the fluff or the after hours nice to have, but need to have and part of an accreditation standard and therefore deserves to be treated as such.
Yeah, and we actually have a new SIM project manager at DMNB, shout out to Craig, who really has been able to implement a ton of simulation, maybe not always interprofessional, but at all the distributed sites. And next week, I'm traveling up to Fredericton on Monday in order to take part in, we're calling a kind of a pilot project, where we are going to have third-year students who are at the tail end of their LIC year, and they're going to do a couple of simulation events involving UNB Fredericton nursing students, as well as some NBCC respiratory therapy students who are in clinical rotations in Fredericton. So again, there's lots of opportunities out there, and I think in New Brunswick we have to think smarter or work smarter, not harder. There's often programs that NBCC is involved with, and it's a matter of making those connections, inviting those students to participate. Their faculty are always over the moon when they get an opportunity to participate. We actually had students come from the St. Andrews NBCC program on this past Saturday from the practical nursing point of view, and that's new. We've never had that before. Last year, we had some pharmacy tech students come from NBCC in Moncton. So I think that we're not 4, 5, 6, 7 hours away, our different centers. So I think there is plenty of opportunity for IPE in this province to expand. There is a core group sort of looking at simulation in the province and how to best use the equipment that is largely siloed in different academic institutions. If everyone has a mannequin, but it's underutilized, it's kind of a bummer. So I think there's lots of opportunities to invite partners to get together and do some simulation, but also have a focus on interprofessional education in kind of a sneaky way. Because any kind of a sim involving the emergency room, like good luck doing that just with medical learners, right? It's very unrealistic for those med students to be assuming roles that they're not trained for and they have maybe only a cursory knowledge of. But if that's who you have to sim, then you say, well, I guess I'm taking on the role of what a respiratory therapist does, or what I think a respiratory therapist does.
For sure. Oh my gosh, brilliant. Well, Marc, let's close with the we have not used the word multidisciplinary out loud during our time together. And like, if I recall some of like the real, I guess, I think you said poke the bear. We were talking before, like what is the difference between interprofessional education and multidisciplinary? And maybe we just need to like, cancel multidisciplinary as a word. I don't know.
Right. Old habits die hard, but language is important, as we know from a number of realms. And I think that if our language around other things can evolve, maybe the language around interprofessionalism can expand as well. Oftentimes people will talk about, oh, that's a multidisciplinary clinic. But if you want to be very technical, a discipline is a subdivision within a profession. So I participate in cleft lip and palate clinic, and in some ways that is an interdisciplinary clinic because we have surgeons from different disciplines, but they're all within the profession of medicine. So we have ear, nose, and throat surgery, we have plastic surgery, we have oral maxillary facial surgery involved, but then we have other professions that are tied to that clinic too. So we actually have an orthodontist that comes to that clinic. We have speech-language pathology involved with that clinic. We have audiology involved with that clinic. So that truly is interprofessional. Whereas if you had only surgeons or plus an MD and pediatrics involved, then you could call that an interdisciplinary clinic. So interprofessional is looking at different professions. And if you want to be further technical, saying that it's interprofessional means that you have some sort of a team meeting following the interaction. If a patient was to come on a day, on a Tuesday, and see different professionals, but there's no kind of tying or unifying conversation around it, say they came into the building, They saw the dietitian in the diabetes clinic, and then they went upstairs to see their diabetes provider, and then they went somewhere else in the building to see a dietitian. You could call that a multi-professional clinic, but it's interprofessional when the professionals get together and have a team meeting or a debrief. And very often in our small clinic setting in Clinic 2 at St. John Regional, we're all sitting in the same room waiting to go in to see the patient. And it's interesting, I often have students follow a patient or a family through the clinic experience. And I say, take note of what sins the various patients or families will. Who do they confess their sins to? They tell the dietitian something that they don't tell the physiotherapist, and they tell the physiotherapist something that they don't tell the pharmacist, thinking we're not sitting in the same room talking about them, right? So we get to hear all the nitty-gritty pieces, but you'd have to be a fly on the wall with each of those interactions to hear them firsthand unless you do have a debrief. So that's a little bit about multidisciplinary versus interprofessional. So I'd encourage your listeners to think more broadly about, is my team interprofessional, or is my team multidisciplinary, or is it multi-professional because we don't have an opportunity to sit together? And I think that a lot is learned when you're providing care when you actually do sit together, because maybe I learned something that I'm not going to document due to sensitivity, but that I could share with a group to hear that. And if it's not documented, it doesn't necessarily exist unless you have an opportunity to speak amongst yourselves, if that makes sense.
We promised that this podcast would not go as long as it has, but this has been so amazing, and I just can't help myself. What's the next frontier, Marc? Is it having the patient in the room to be part of that collaborative conversation at the end? Or is that just too challenging to think about, or is that even thought about?
My short answer in diplomacy would be, I think it would depend upon, again, thinking of the peds world, because that's how you and I spend our days. I would think it would depend on the patient. It would depend on the family. It would depend on how open the team members would feel that they could speak. It would depend on what information the family could handle having shared in front of them. So I'll say my focus is more interprofessional education rather than interprofessional collaboration, and punt it down the road at that point.
Yeah, but I think it's so interesting to think about, because I think our healthcare reform now, here we are having this conversation in 2023 and talking about what is the next frontier of being able to deliver healthcare in a way that really meets people where they're at. And I don't know the answer either, because, we talk a lot about having the patient in the center, hearing the patient voice. And so then how do we do that in a way that, enhances the quality of care? And sadly, well, not sadly, I'll take that back, but the efficiency, because I think everybody benefits from efficiency as well, but the quality of care for people. And so what does that look like? And of course, one size doesn't fit all, but just always sort of thinking about health systems too in the future. So Marc, oh my gosh, thank you so much, first of all, for all the work that you do with this, which, even though, the 30 years we've known each other and the fact that we work down the hall, often I really didn't understand the breadth of everything that was going on. And so I think a wonderful, wonderful story to tell DMNB faculty and faculty beyond. So sounds like there's lots of chance to get involved and lots of time to do so, because your events will be a year from now for the most part.
Yes.
So people will reach out to you.
Sorry?
So we'll get people to reach out for you. Well, you're accessible with Dal email and all the rest, I'm sure.
The other thing, too, is that I've accepted another 3-year position in this role. But when I'm done, it'll be almost 10 years. So I think it's probably time for sort of a new set of eyes, so to speak, and new thoughts. And so I'll put that out to your listeners. If you're at all interested in interprofessional education, I think that I will feel very sensitive as to who follows in my role. So I hope there is an IPE champion out there who, when the time comes, is the right candidate for the position. So if anyone is interested, or they want to learn more about IPE, or they think, oh, that might be something interesting to get into, you have 3 years to think about it and get ready for it. So I'm happy to have people reach out to me to talk more about IPE.
Wonderful. Thanks a million for coming, Marc. Nice to see you as always. And get in touch with Marc for all your things interprofessional education.
Thank you, Sarah.
Thank you for listening to the Fac Dev Lounge podcast. Please leave us a review on iTunes, YouTube, or SoundCloud, and even a comment on some ideas for future podcasts. Thank you very much and have a great day.